Welcome to the EUPSA webinar, Controversies in the Management of CPAM. My name is Martin Lacher. I have the privilege to chair this session together with Arnaud Bonnard from Paris, France, Paola Midrio from Treviso, Italy, and it's also an honor to have several to the EUPSA webinar, Controversies in the order of their talks. I welcome Nigel Hall. He is Associate Professor and Consultant of Pediatric Surgery of the University of Southampton. Juan de Agustin, he is Professor of Surgery and Head of Department, University of Madrid. Martin Metzelder, he is Professor of Surgery, Head of Department at the University of Vienna. And Dr. Nazia Ken Dunlop, she is Consultant of Pediatric Surgery at the Necker University in Paris, France, with a special interest and expertise in treating CPAM. So it's a true European endeavor we are doing today, if you still consider UK as a part of Europe. So, well, the format is like a scientific battle. We will have a pro talk and a con talk, more or less like boxing, the left red corner and the right blue corner. So after the two talks, pro and con, you can, or while the speakers are talking, you can pose questions in the chat room on Facebook, and the two moderators, so Arnaud, Paola, and me, will select some of these questions and then speak them out loud to the speakers. So the first session is the topic, only symptomatic patients should undergo surgery. That's the hypothesis. And well, as I said, in the red corner is Nigel Hall talking pro, and in the blue corner is Juan de Agustin talking con. So Nigel, are you ready?
I think so. Let me try and get the technology to work. While I'm doing that, Martin, just let me say thank you to you in particular for driving this initiative and trying to ensure that the EUPSA has some ongoing education during this difficult time for everyone. Hopefully you can see some slides. Can you see the slides?
Yes.
Yeah.
Okay, so I'll start. Thank you very much for the introduction. I have one disclosure, which is in keeping with the title of my presentation today, which is not so much a disclosure, but this is truly what I believe, and this is what I practice in my clinical practice in the clinic, that when these lesions are not causing any symptoms, that actually observation alone is a preferable approach to routine surgery for these children. So let's just consider for a moment exactly what we're talking about. All of you will be familiar with the spectrum of congenital lung malformations. Obviously, the lesions we're talking about today, the congenital pulmonary adenomatous malformations, are part of a spectrum of these lesions, which may be diagnosed prenatally or postnatally, and have a number of different characteristics, both clinically and on imaging. So we're just going to be talking about the CPAMs today. I acknowledge that there is some overlap with the bronchopulmonary sequestrations, and there are these hybrid lesions which contain features of both CPAM and sequestrations. What we're talking about today is the lesions that are asymptomatic. And what we have to do as clinicians, in conjunction with the multidisciplinary team that of course includes the parents, is weigh up the risks of surgery that will be familiar to all surgeons here against the risks of observation. And some of these risks of surgery you would appreciate are specific to any particular operation. The ones I guess that are specific to resection of part of a lung relate to having an air leak, and some may view that actually, well, having an air leak for a short period of time is not the end of the world. But there are more significant risks around that I'll come to in a bit more detail in a while, particularly catastrophic hemorrhage, and in fact, in some cases, the risk of death from elective surgery in asymptomatic children. There is a belief that if you perform surgery and remove an abnormal part of lung, then you may be impairing pulmonary function in the long term. And the other thing that I don't think there's been much literature on at all is, of course, around the cost of these two approaches. whether, and clearly surgery carries a vastly higher cost implication than non-operative observation. When we consider the risks of observing these, there are a number of potential complications along the way that clinicians get concerned about, and these are the main drivers that cause or result in clinicians performing surgery. So there's a concern that these may become infected, the child may become unwell, and in that case, there's some suggestion that the surgery to remove a lesion afterwards may be more difficult and have a higher complication rate. There's a feeling that if you can remove a part of the lung that is abnormal early enough in life, then you can allow for compensatory lung growth to occur. We know that alveolar development continues up to about the age of 5 years. And so if you don't allow that compensatory lung growth, then that might result in long-term pulmonary insufficiency. The key thing that seems to drive a large emotive response is the possibility of a risk of this not being a benign lesion but causing a cancer, and what we'll see is some data related to that is exceedingly rare. And then of course is the chance that if you're observing a lesion that's been found there before birth, that there is some parental anxiety which may require managing, and in fact in some cases may be actually the reason to consider performing surgery. I thought I'd just highlight some series from some large series that have been reported within the last 5 years or so related to this. So there's nothing that puts surgeons off doing surgery than having complications. And so this is a study from North America looking at resection of pediatric congenital lung malformations in just over 250 children, the vast majority of whom were less than a year of age. And they found a total nearly 20% chance of complications. Okay, so this is a relatively high incidence of complications in this population, and particularly when you're considering that these children are asymptomatic, then we need to weigh up very carefully whether the risk of developing a complication is truly justified. I highlighted this paper really just to highlight this problem about death, because people who have not scrutinized the literature carefully do not realize that there are cases reported of mortality from elective asymptomatic resections of these lesions. So this is a series of 860 cases. Again, the majority were less than a year of age, again from North America. But there were children who died after having this sort of surgery. So again, just emphasizing you need to be able to truly justify your indication for doing this sort of operation. A series that I was involved in from Toronto in Canada. So we highlighted and isolated children who were prenatally diagnosed and truly asymptomatic, who were having elective lung resections despite having no symptoms. So this was a combination of either clinician or parent choice. Their mean age was 6 months. And we identified at least one complication in 23% of cases. And 3 of these were major complications, and 2 of these were potentially life-threatening complications, and one of which had significant ongoing consequences for the child involved. Again, I highlight elective surgery, asymptomatic children, chance of potentially life-threatening complications. I'm aware that deaths have occurred in this population, but there's no doubt that there is a lot of reporting bias. People do not like to report cases that have not gone well. But I'm aware of at least 3 children in North America who have died following asymptomatic lung resection for this sort of problem. There's one case within this series from 2000 of a case of a child who's died, but that's the only case I'm aware of that has actually been published. But I'm certainly aware of other cases, and talking to other surgeons around the world, they're also aware of other cases. They just don't get reported. So overall, surgery may not be as low risk as we're truly appreciating. I accept that these risks of serious complications are low, but they are not zero. and the complications that I'm talking about are significant, with significant life impact. Furthermore, there are other clues that surgery may not be the cure that you're actually anticipating. Many surgeons propose doing surgery to prevent symptoms in the future, but actually there are a number of reports that actually symptoms do occur, and symptoms actually even develop in these children after resection of the abnormal lung. The lung growth that I mentioned earlier, the compensatory lung growth following an early resection does not always occur. And there are also concerns about cosmetis, particularly with open surgery and increasing incidence of chest wall deformity. There is undoubtedly a cost implication to elective surgery on asymptomatic patients, but I've not seen published any data relating to that. But it is certainly, as surgeons, we're being increasingly asked to justify the cost effectiveness of our interventions. So this has to become a relevant part of the argument. So that's my feeling why you shouldn't do surgery. Let me tell you what I think about some of the arguments also against doing observation. So why do these risks not matter to me as much as the risks of doing surgery? So let's consider infection first of all, because the infection and cancer risks seem to be the prime drivers that surgeons use to persuade parents sometimes, or to recommend to patients that they undergo surgery. So this is a systematic review and meta-analysis of how some of these lung lesions were managed and what their features were of over 500 asymptomatic infants. So less than 1 year old was the criteria for inclusion. And this study found that only 3% of these lesions actually became infected during that time. So it may well be that the chance of infection in one of these lesions is actually a lot lower than we think it is. So malignancy is the thing that drives people's emotions, understandably so. And the challenge here is being able to say with certainty that this is not a malignant lesion. And the controversy is around whether these CPAMs degenerate into tumors, whether they're actually CPAMs or actually tumors, and about the histological appearance of these tumors. And there are two tumors talked about in association with CPAMs. First of all is the bronchoalveolar carcinoma. This is typically a cancer of old people with a strong association with smoking. And then, of course, pleuropulmonary blastoma, which was previously known to some people as a rhabdomyosarcoma of the lung. So let's just take this first thing. So this has never been reported in an antenatally diagnosed asymptomatic CPAM. There are a handful of cases worldwide in children, but it's never been reported in the sort of problem we're dealing with. And bear in mind that the sort of problem we're dealing with is in children who are have an incidence of 1 in 2,500. So if this was going to be a main problem, we should have seen it. The pleuropulmonary blastoma, or PPB, is even more rare. And we are talking about only ever 4 case reports of tiny foci within this lesion have been reported. So these data suggest really that the cancer risk is pretty much zero, and really has never been truly reported in these sorts of lesions. One final word: the observation of these asymptomatic CPAMs does not mean do nothing. You can monitor these for symptoms. You can monitor these radiologically if you desire to do so, and you can attempt them. And when they do develop symptoms or do develop concerning features, they can be resected. But for the vast majority of them, they can be left alone. And here is a report that we worked on a couple of years ago about some clinical and radiological features that can help that distinction. As I mentioned, there are some increasing voluminous series of lung malformations that I won't go through now in detail for the interest of time, but essentially these papers come out supporting that asymptomatic lesions do not need surgery. You can leave these well alone. The the symptom development is very low. Yes, they have some respiratory symptoms like normal children do, but none of these in this series were admitted with pneumonia, and none have undergone surgery. And the series from Great Ormond Street I highlighted earlier, similarly, 70 cases observed without surgery, 10-year follow-up. None have caused any problems. The infection risk is low, and in fact, some of them spontaneously resolve without any surgery needed. Coming on to spontaneous resolution, this is just something to be aware of. This is a child treated here who had a significant radiological abnormality at birth, and at 4 years of age, the child is asymptomatic and has gone on plain X-rays. The child remained asymptomatic, and in some series, up to 14% spontaneously resolve. So when we come back to our risks of surgery and our risks of observation, we have to balance these things up. But my feeling is that the risks of surgery significantly outweigh the risks of observation, and therefore in these asymptomatic children, observation without surgery is a preferable approach. Some of you will have heard of Siggy Ein, a surgeon from the Hospital for Sick Children. He had a saying that you can't make a well child better. These children are well, they are healthy, they have no symptoms. And therefore my proposal is that when a CPAM is not symptomatic, that observation alone is preferable to surgery. Children without symptoms do not need an operation. Just one final word before I finish is that we understand that this is a controversial area, and we are launching later this year, once the pandemic is over, an international lung malformation registry, and would invite everyone to submit cases prospectively to this so that we can understand better about the natural history of these conditions and generate an increasing body of evidence to support our clinical practice. Thank you very much.
I'm ready for counteract to Nigel.
Okay.
Okay, Juan. So Juan de Agustin is a professor in pediatric surgery in Madrid. He is working, and one of his preferred topics is congenital pulmonary malformations, and he will speak about the alternative for the treatment of CPAM, and obviously the surgical treatment of this, and trying to convince us against Nigel to operate on these patients. So Juan, go ahead.
So
Wonderful.
Thank you for giving me the opportunity to give a talk on this topic, because we do really think that asymptomatic CPAM patients has to be operated on. And these are the reasons, because we don't know the natural course of the disease. So I agree that the registry focus on this topic will be very beneficial, because we don't really know which is the real course of the disease at the long term. So I will try to say why we operate in asymptomatic patients, and try to answer if surgery is safe, and which are the complications and the results. So going back to this work from Great Ormond Street, we can see that the risk of recurrent infection in asymptomatic patients, followed by a median time of 9.9 years, is less than 10%. 68 patients were managed conservatively, but 16 were out of the follow-up. So 52 were followed and observed no complications, but in another, they had symptoms, so they had to be operated on by because of the CT images that evolved in time, or they had a recurrent infection, or there were unclear images that had to be addressed. So there were only 2 elective medically advised surgeries. The median age at at time of the surgery was a little bit earlier in the group without infections. The patient that had repeated infection, they were operated on up to 5 years of age. But what is also interesting in this work, that inflammation was observed almost in half of the specimens they took from the operation. So even though there was only 10% of patients with infection, 50% of them showed some kind of inflammation. So asymptomatic patients can have also inflammation in the specimens. So these are the arguments why early surgery is fine. Even malignancy rate is really low. The risk of malignancy is eliminated. Also, of infection and pneumothorax are complications observed in observed patients. Pneumothorax is not very common, but infection can present, especially in the first few years of life. And it's true that it's a compensatory lung growth following resection, but this lung growth takes place especially in the first 2 years of life. So if we want to benefit of this lung growth compensation, it has to be done before the first year of life. Also, what is really important, and I will go to show you, that post-operative complications following elective surgery in patients that had complications before surgery, like infection, they show much more complication after surgery. And also, what it has been commented that avoiding long periods of observation can reduce the anxiety of the parents. Also the less of radiation that has to be done in repeated CT scans or X-rays of those patients, and during and loss of follow-up. These are the main reasons. So talking about malignancy, these are the two main tumors that are related to the CPAM. Bronchoalveolar carcinoma has been developed in only type 1 CPAMs, and pleuropulmonary blastoma is related to the type 4. But what is really important sometimes in diagnosing pleuropulmonary blastoma is to try to distinguish the radiological images from CPAM. That is really sometimes the question. But also there's a very interesting work from Pelizzo et al. That they were studying CPAM mesenchymal stromal stem cells, and they could show that they exhibited the specific features similar to the tumor-derived MSC cells. So this abnormal tissue has malignant potential. These cells are considered important players in the tumor microenvironment, and they have been closely linked to regulation of tumor survival, growth, and progression. So their advice is that resection in asymptomatic patients might be indicated to exclude this microenvironment that can be potential tumor progression. Another interesting paper is talking about prophylactic operations associated with some malformations, because at the end there is a lower rate of complications if we can prevent the development of tumors, and is a higher cost effectiveness in annual screening and routine examination. So cost is considered here. There are some genetic predisposition syndromes, like in MEN2 or familial polyposis, or hereditary non-polyposis colorectal cancer, or hereditary diffuse gastric cancer patients, but also in non-genetic lesions studies, like CPAM, that is included here in this group. There are 9 studies that are prone to do surgery for CPAM. And complication during observation, mainly infection, it has been estimated in a low rate, but as low as 3% or even 10% during the first 5 years. We don't know in the long term what is going on with these patients, but we have seen in the past several lung abscesses that when they were removed, we found some CPAM histologic features. Also, another important part of the surgery is that surgery is performed in asymptomatic patients. We are going to see less complications during and after surgery. And when surgery is performed in symptomatic patients, there is a 3 times more rate of complications because of the surgery. So this is another review meta-analysis that favors, because of less morbidity, favors early surgery before symptoms occur. But it couldn't demonstrate that it's superior in terms of hospital stay. That is the same like with both groups. Another paper showed us similar complication rates and a little bit better results in early operation when it's performed less than 4 months than later. This is the group, but most of them in this group, they included not only CPAM, they included as well bronchial atresia, lobar sequestration, either extralobar or infralobar, bronchogenic cysts, and others. So it's not very much representative of CPAM properly, but it shows that early resection has less complications. So at the end, we have to think about the natural course of the disease that is unknown. Of course, symptomatic patients has no doubt that they have to be operated on. But in asymptomatic patients, we must advise surgery because we can completely eliminate, even if there are small numbers of that, but we eliminate the risk of malignization or misinterpretation of the doubtful images that we can see in the explorations. Surgery, when it's concentrated in a very small number of surgeons, that like we do in our department, there is only 2 surgeons dedicated with this kind of surgery, is safe, really safe. So when this surgery is done by a lot of people and they have low numbers and low experience, you will find more complications, of course, and could be surgery unsafe. But we have to have dedicated people to do lung surgery, and that's the way we are doing. Long periods of observation also cause the loss of follow-up and irradiation and anxiety, and so we can, in the good settings of safe surgery, we can avoid that. And finally, thoracoscopy is even better if we can do it very early. In our protocol, we do surgery between 6 months and 1 year of age, so thoracoscopy can be done very safe. And in that period of time, lung growth is observed, compensatory lung growth. And finally, open thoracotomy, we found that is better in neonates, especially if they are symptomatic, and thoracoscopy is safe in patients when they are more than 6 months old. And thank you very much for inviting me to this opportunity. Thank you.
So we have some questions from the audience, and especially some questions for Nigel. And Nigel, you mentioned in your talk that you could have an impair of the lung function by surgery. Do you have a study to prove that or to explain that?
Thanks. That's a good question. So there are very few studies about this, and the studies have been done. It's difficult to know whether the lung function changes are related to surgery or to the underlying disease. But we know that many of the lesions that are removed are small. And of course, the easiest way for most people to do a lung resection is to do a lobectomy. I know some people are doing segmentectomies or non-anatomical resections, but most people are doing lobectomies. And so the thought is actually that you may be removing a bulk of normal lung tissue alongside this very small area, and therefore impairing lung function in the long term. Of the studies that have been done, the lung capacity seems to be preserved, but the FEV1 seems to be reduced in some of them. So it's not clear. Perhaps it's more a hypothetical reason, but certainly there is a concern about taking away lung that is essentially normal alongside this lesion.
Okay. Nigel, there is another question, a couple of them that go together. If you decide not to operate, then means you want to follow your patients. So is a clinical observation enough, or you may want to follow them radiologically? And if it's yes, which kind of radiological imaging you want to take to be sure that the follow-up is reliable?
So that's a good question, and I think there is not complete good understanding about what the most appropriate follow-up for these patients is, and I acknowledge that. What I do is we do an early chest X-ray and a CT scan around about 3 months of age, and if we feel that this is a suitable candidate for non-operative observation, as in there are no concerning features on the CT scan, then I see them at 6 months and a year for clinical review and with a chest X-ray. And then I monitor them every year up to about 5 years of age. And important of that is discussion with the parents about making sure that the parents are comfortable with non-operative observation and an understanding between you of what the things that would change that course of treatment are. And the vast majority of the time, that is going to be symptoms, because you've done the CT scan and you found there were no concerning features on the CT scan. So in my mind, if you're only going to operate because of symptoms, there's no point in carrying on doing the radiology beyond the first few years of life. So beyond about 4 or 5 years, are guided by the symptoms alone. If the parents are keen to have further imaging, then I certainly start with a chest X-ray beyond that stage. There are some people who recommend doing MRI scans to remove the need for radiation, and I agree that that may be a useful thing to do, but we haven't done that yet, partly because in many places getting regular MRI scans on these numbers of patients is simply impractical. But it's certainly something that I think with further prospective study, such as through the registry that we're proposing, we could get some further information on about this, because there will be people around the world who are doing MRI scans. But for me, clinical review is the main part of the follow-up.
So Nigel, because considering a publication 3 or 4 years ago about from the European Task Force on lung malformation, what was stated is that if we don't operate them, which was quite clear, because of this risk of cancer, which very rare but obvious, the follow-up has to be done all lifelong, and the only way to be sure that it will not turn to PPB or cancer is CT scan. That was the conclusion of this task force working all together. So it's not that easy. The answer is not easy, but I think definitely that just X-ray is not enough. And if we leave the malformation in place, we have to follow them all lifelong. That's the main point. That when I joined Juan, that for the parents and for the family, it's also a stressing point that has to be taken into account. Maybe yes, maybe not, but it's also an important point.
So I appreciate that people have got views about this. My view is that the risk of malignancy in these lesions is hugely overestimated. These lesions have been around for many, many years, before prenatal ultrasound existed. And if there were a real risk that these lesions were going to become cancerous in the longer term follow-up, then we would be having chest surgeons, adult chest surgeons, telling us that they were seeing lots and lots of these cases of lung cancer in young people that were missed congenital malformations. And we simply don't see that. We simply don't see that. The risk of any of these patients developing a cancer anywhere else in their body, or even developing lung cancer because of other causes, is almost certainly higher than having one of these lesions that is asymptomatic turning into a cancer in long-term follow-up.
But Nigel, there are publications on adult surgeons talking about this cancer degeneration linked to KRAS mutation and so on. So it's not that often that there are publications stating that.
But I think just because something is published doesn't necessarily mean that the volume that is out there can justify what is going to happen. So I accept there may be underlying conditions that predispose to this. So if you take PPB, for instance, then it is recognized that there are germline genetic mutations such as in DICER1, and it may be possible to screen some of these people for that and to look for other cancer families or familial cancer syndromes that may have a higher predisposition to developing this. But we just simply don't see the volume of patients that justify this.
Thank you, Nigel. Thank you, Nadia. We have to move on. We have to move on, otherwise we will be late.